This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026. The paper is titled, Immediate Postoperative Outcomes of Burr-hole versus Bone Flap, a Hounsfield Unit Threshold in Subacute Subdural Hematoma.
This is a topic that hits close to home for anyone who has ever covered a trauma call. We're talking about the gray zone of neurosurgery, the subacute subdural hematoma, SDH. Alara, why is this specifically such a point of contention in our field?
Well, Dr. Eris, as you know, the surgical management for chronic SDH, usually the more liquid, motor oil consistency, is typically a 2-burr-hole craniostomy. It's minimally invasive and effective. On the other end, for acute, solid clots, we almost always go with a larger bone flap elevation or craniotomy to ensure we can actually evacuate the mass. But subacute cases, that's where the uncertainty lies.
Exactly. In subacute cases, the hematoma is in transition. It's starting to liquefy, but it often retains a solid component. The dilemma we face at the scrub sink is, will burr holes achieve adequate evacuation? Or will I get in there, find the clot is too thick, and be forced to convert to a craniotomy?
That's exactly what this study addresses. The authors point out that while the choice is usually straightforward for acute or chronic cases, subacute cases leave us guessing about the internal architecture of the hematoma. They propose that we stop guessing and start measuring. They looked at a hematoma density threshold using Hounsfield units, or HU, a non-contrast computed tomography.
It's a classic problem of subjective versus objective assessment. We've all looked at a scan and thought, that looks a bit too bright for a burr hole. But bright isn't a measurement. Using the HU as an objective guide is a significant step forward. What did the study specifically look for in the immediate postoperative outcomes?
The researchers compared 2-burr-hole craniostomy against bone flap elevation. The primary concern was whether the burr holes provided enough reach to evacuate the subacute collection. If the HU is too high, meaning the blood is more dense and closer to its acute state, the burr hole might fail to achieve adequate decompression.
And that's the nightmare scenario. If you choose burr holes and the immediate postoperative CT shows a significant residual hematoma with persistent mass effect, you've essentially performed an incomplete procedure. You might find yourself back in the OR for a rescue craniotomy within hours.
Precisely. The paper suggests that by establishing a specific HU threshold, surgeons can make an evidence-based decision before the first incision is made. If the hematoma density on the non-contrast CT is below a certain Hounsfield unit threshold, the study suggests that 2-burr-hole craniostomy is likely sufficient. If it's above that threshold, a bone flap elevation is indicated to ensure adequate evacuation.
It's interesting because this moves us towards a more personalized approach to SDH. Instead of just saying it's been 10 days since the injury, so it must be subacute, we're looking at the actual physical density of the blood in that specific patient.
And the immediate part of the study is key. By focusing on immediate postoperative outcomes, they are looking directly at the mechanical success of the evacuation. Did the surgery do what it was supposed to do right then and there?
It also has implications for operating room efficiency and patient safety. A bone flap elevation is a more involved procedure than a burr-hole craniotomy. There's more blood loss, longer anesthesia time, and potentially more complications. If we can safely do a burr hole because the HU tells us it will work, that's a win for the patient. Conversely, if we know the burr hole will fail because the HU is too high, we save the patient from a redundant procedure by going straight to a bone flap.
Right. The study really emphasizes that this HU threshold offers an objective guide to resolve that uncertainty we mentioned earlier. It's about matching the tool to the pathology.
This is definitely something for our residents to keep in mind when they're presenting these cases in the ER. Don't just tell me it's isodense. Tell me what the Hounsfield units are.
It definitely adds a layer of precision to our preoperative planning. It will be interesting to see how this threshold gets integrated into standard trauma protocols over the next year.
Well, that's all the time we have for today. An excellent look at a very practical study. Thank you, Dr. Alara.
Thank you, Dr. Eris.
To our listeners, stay tuned for our next episode, where we continue to dive into the latest in neurosurgical research. Until next time.